Greetings from Lymphoma Myeloma 2016 here at the Waldorf Astoria Hotel in New York City. I am Dr. Morton Coleman. I'm the director of the Center for Lymphoma and Myeloma at Weill Cornell Medicine, New York Presbyterian Hospital. We are going to be discussing key insights from the meeting today. With me is Professor Ruben Niesvizky, who heads up our Center of Excellence in Multiple Myeloma. Ruben, greetings.
Hello, how are you?
Thank you for coming. Ruben, today was a very exciting session and we heard a number of interesting new and innovative treatments and insights. One of them that I was very impressed with was the importance of minimal residual disease. What is your take on minimal residual disease in myeloma and its therapeutic implications?
Thank you, Morton. I think it's important to point out that the sessions were all very exciting. The first session was on basic and translational science, and then we had two very informative and exciting clinical sessions. In the first one, we were able to dissect the biology behind resistance to immunomodulators, and the investigators talked about the consequences of mutations in cereblon as a manifestation of resistance. The mechanisms by which cereblon works were also dissected, and it was very interesting because that may have potential repercussions in the treatment. Also, we had the opportunity to hear about precision medicine in myeloma, and although it was recognized that we still have much work to do, a subtype of myeloma bearing translocation 11-14 might be a first target for newer agents such as venetoclax. However, we still have to learn all the subtleties in the translocation 11-14 disease. The third part was indeed, as you said, minimal residual disease. And I think it's clear that achieving minimal residual disease or an undetectable point on that minimal residual disease is important for outcomes. The more profound and deep responses you can achieve, the outcomes improve. The greater question is what are the measures or the techniques that we use to measure and how deep we can go. We spoke about the virtues and liabilities of flow cytometry. We spoke about immunohistochemistry, and we also touched upon next generation sequencing as best ways to detect minimal residual disease. And we concluded that we have much work to do, particularly trying to find markers in blood and urine that can obviate the need of using imaging also as a manifestation of response.
So tell me, is there any one level that we've been able to agree on of minimal residual disease? How far down do we need to go? The further we go, the better we are? And looking one day not to be able to detect any disease
or
at
a
all,
single cell,
and looking for cure? One of the problems we have, of course, is that myeloma can be spotty disease, and one wonders that even if you're MRD negative in one particular area, would you be MRD negative elsewhere? I guess that's the advantage of being able to do something from either blood or urine, which still remains just on the horizon.
Proteomics would be a way to go, or circulating DNA, or other forms of detection. The best available data suggests that go to 10 to the 5, 10 to the 4 is still feasible, although time-consuming and difficult to assess, as you need always a baseline sample to follow. And as you said, there are other deposits of myeloma that might not be detected by bone marrow, and therefore other markers are required.
It seems like circulating DNA holds a great deal of appeal. They're using some of that now in some of the other tumors, and hopefully one day we'll be able to do the same for myeloma. One of the other exciting advents at this meeting is the use of monoclonal antibodies, particularly daratumumab and elotuzumab, which are already on the market, and others that are coming down the pike. Would you care to comment on where you see these monoclonal antibodies fitting in our medical armamentarium against myeloma?
It's also very exciting that in the last year, about 5 new drugs have been approved, and the latest have been, as you say, the monoclonal antibodies, elotuzumab and daratumumab, one recognizing SLAMF7 as a bifunctional form of therapy that targets both the NK cells and the myeloma cells in the other hand, activating the NK cells and engaging the myeloma cells by opsonizing them and inducing cellular lysis by ADCC. The data shows a very sustained difference at 1, 2, and 3 years of progression-free survival advantage for the use of elotuzumab, and it has been recognized that has the lesser amount of adverse events or severe adverse events. So in general, it is preferred in patients who are infirm or older. In the other hand, daratumumab appears to have greater single-agent activity, and first approved as a single agent for patients who were refractory to 3 different agents, including proteasome inhibitors, immunomodulators, and refractory to the last line. However, now there's good data on randomized trials, one in combination with lenalidomide and dexamethasone, and another one in bortezomib and dexamethasone combination, both showing very impressive hazard ratio for progression-free survival in the 1 to 3 lines of therapy arena. So I won't get surprised if we start using these agents early enough, and even as upfront treatment, which offers an alternative way to treat the disease and appears not to care about the cytogenetic risk. So it is very interesting that we can start thinking of an R-CHOP type of therapy for myeloma.
Well, you know, it looks like this CHOP-R therapy theory, since it's worked in lymphoma, is something that we hope will work in myeloma as well, although I think myeloma is more akin to indolent lymphoma rather than aggressive lymphoma, which is potentially curable.
The greatest challenge, though, is that we have both in myeloma. We have a phase of myeloma that, as you say, is the most indolent, and it may be treated as a chronic disease. But on the other hand, we have highly proliferative, high-risk myeloma, and that has been recognized as one of the greatest challenges. Those patients may require a more aggressive therapy.
So one of the issues has been, should we bring up some of what we think may be more potent agents, carfilzomib and pomalidomide, up front, and combine that with dexamethasone and daratumumab to make a CHOP-like regimen. And we do know that when you put carfilzomib with pomalidomide and dexamethasone, you get rather profound responses. And I'm wondering, do you think if we are able to achieve really significant MRD with, for instance, this one combination, would it be necessary to do a transplant if you got the same degree of MRD? Or do you think transplant does, with the high-dose therapy, does something other than what these biologic or targeted agents would do?
Paraphrasing one of the investigators that spoke, it is clear that high-dose melphalan and stem cell support is another line of therapy, albeit very effective, and should be considered as such. I think there are patients who are MRD positive who would benefit of further consolidation therapy with high-dose therapy. On the other hand, we and others have elected to harvest stem cells and use it in salvage. I think the question still remains what is going to be the future role of high-dose melphalan and other high-dose therapy with stem cell support.
Would you like to address the issue, which wasn't so clearly addressed in the meeting, of doing a stem cell transplant early on, where you throw all of your armamentarium at the particular illness, or waiting for relapse and then using a stem cell transplant. There's a little bit of controversy on it. What is your feeling about this, doing it early on versus at relapse?
I think it's, as I said before, I think it's not the treatment or the treatment modality what makes the difference, but rather the ability to achieve MRD negative state. So
whatever that may be.
It could be that you need to achieve that goal of 10 to the 5 somehow. So if you didn't achieve it with a combination such as the one that you postulate, then high-dose therapy will be indicated. But in those patients who can MRD negative can be achieved, like presented by some of the investigators using RVD, they might not need to do transplant in that group. I think it's going to be fundamental also the role of maintenance.
That's what I was going to bring up next. Should we maintain indefinitely? Should we maintain for just a limited period? Should we not maintain at all? We had a debate on that. What is your take on maintenance therapy? And what kind of maintenance therapy?
I have the bias that continuous therapy is an important aspect of treatment, and I don't see ever clear evidence that continuous therapy will induce more aggressive relapses or significant adverse events such as secondary primary malignancies. The rational use of maintenance, I think, is clear. We have to learn, however, what would be the effect on MRD sequentially, and that will teach us if it has to be given continuously or interrupted. Currently, I think the recommendation is maintain until progression. Now, the agent is still a question. Lenalidomide is the one with the more mature data, and recent meta-analysis show advantage even in survival for lenalidomide maintenance. So I think that supports the use of lenalidomide maintenance in an uninterrupted way. I think patients with high-risk cytogenetics and other forms of high risk might benefit of combining lenalidomide and bortezomib, but data is not available on that arena.
Right. So, but there is some controversy, is there not, about whether you really enhance survival with maintenance. There's no question that progression-free survival is markedly enhanced by maintenance. But there is the contention that if you wait for the relapse and then retreat, that you can get the same sort of survival. I gather you don't ascribe to that, and you feel that the longer they stay on maintenance, the greater your chance for getting a more profound MRD. Would that be correct?
And lesser clonal evolution. So you can ameliorate or reduce the emergence of new clones by continuing maintenance therapy.
So if I may paraphrase you a little bit, there are 3 take-home messages. One is that MRD is coming into its own, and that we are still doing work on it, but it may be very significant in how we choose what our therapy is. 2, that you feel that maintenance is of value. And 3, that the monoclonal antibodies are adding an enormous amount to our ability to achieve MRD and to get good clinical responses. Would that be correct? Those are 3 take-home points?
Exactly.
Thank you very much. Thank you very much, Professor Niesvizky. This is Dr. Morton Coleman wishing you a good day.